Faculty of Nursing Universitas Airlangga is a reputable nursing education center located in the eastern Surabaya city, a metropolitan with great ambience and comfortable place to study. In line with Universitas Airlangga motto, excellent with morality, the Faculty of Nursing Universitas Airlangga is committed to produce nursing graduates who are competent, professionals, and good moral insight. The Faculty of Nursing at Universitas Airlangga is the best choice for nursing education. Vision and mission.
Our vision is becoming an independent, innovative, leading a nursing program, a pioneer in the development of nursing science and practice at national and international level based on value, nationality, faith, ethic, and moral of religion. And our mission is organizing and developing the academic education and the nursing profession appropriate science and technology, and then conducting basic research, clinical and innovative community to support education and developing in community services. Organizing dedication on the field of science and nursing practice to the public based on national value, ethic, and moral of religion. And in the end, we are organizing the faculty good governance through development-oriented countries and quality and able to competent at national and international level.
Dean Faculty of Nursing, Vice Dean for Academics and Students, Vice Dean for Staff and Finance, Vice Dean for Research and Collaboration. We have 3 programs in our faculty. There are Bachelor of Nursing with A accreditation, Master Program with A accreditation, Doctoral Program, and Nurse Specialist of Medical Surgical Nursing. And also, we already certified by ASEAN University Nation. Our faculty supporting by 49 academic staff and 25 administrative staff. And also, we have total student body around 1,200 students. We have 3 departments: Department of Fundamental, Critical, and Medical Surgical Nursing, Department Maternity and Pediatric Nursing, and Department of Mental, Geriatric, and Community Nursing. We have facilities to develop students' ability to produce professional nursing skills. We have student-friendly libraries with full access to international database. And also, with several institutions and hospitals collaborations, such as Universitas Airlangga Hospital, Dr. Sutomo General Hospital, Dental Hospital of Universitas Airlangga, and Institute of Tropical Disease. We support Universitas Airlangga goals to be 500 world-class university. We have national and international collaboration. We collaborate with international university for exchange program and increasing research and publication. There are Latrobe University Australia, Flinders University Australia, University of College Coast Island, University of Malaya Malaysia, Naresuan University Thailand, Japanese Red Cross Kyushu International College of Nursing Japan, JICA Japan, UGSI Malaysia, Universitas Putra Malaysia, King Abdul Aziz University, Alvan Hook School, and Oita University Japan. Our students also have a great achievement, both national and international competition. In order to develop student capability, our students are well facilitated through Student Club.
capture, store, access, share, and collaborate around medical multimedia like it's the 21st century. Welcome to Sectra Enterprise Imaging, a consolidated solution made for you. Our solutions are built with an enterprise platform, enabling diagnostic and clinical tools, each tailored to fit your hospital's specific needs. Streamline the complete workflow for any imaging discipline and take care of everything from diagnostics and distribution to management, teaching, and quality improvement. Multidisciplinary collaboration leads to faster and more precise decisions, which can improve clinical efficiency as well as patient outcomes. And with a unified system, you get easy access to all relevant images, data, and patient records integrated seamlessly with surrounding IT solutions. Sectra Enterprise Imaging comes with 24/7 support, designed for 0% downtime with complete data protection, on-premises, or as a cloud service. It's easy to get started, easy to learn, and easy to use, so that your time can be used where it's needed the most. Sectra Enterprise Imaging, made for you.
Faculty of Nursing Universitas Airlangga is a reputable nursing education center located in the eastern Surabaya city, a metropolitan with great ambience and comfortable place to study. In line with Universitas Airlangga motto, excellent with morality, the Faculty of Nursing Universitas Airlangga is committed to produce nursing graduates who are competent.
Assalamualaikum warahmatullahi wabarakatuh. All distinguished speakers, ladies and gentlemen, welcome back to the 13th International Nursing Conference, Continuous Innovation for Sustainable Health and Climate Resilience. Come back with me, Sarah, as your Master of Ceremony. Now we are going to start our second plenary session. And before that, I would like to invite Dr. Ninuk Dian Kurniawati as moderator and Dr. Mira Triharini as note taker for these sessions. Without further ado, we will give this session to the moderator in charge. To Dr. Ninuk, time is yours.
Thank you for the time. The honorable speakers, distinguished guests, participants, ladies and gentlemen. Very good morning, very good afternoon to you all in Indonesia, Australia, and Hong Kong. And good morning to our distinguished speaker from the UK. Assalamualaikum warahmatullahi wabarakatuh. This session will take about 2.5 hours. And in this second plenary session, we shall have our outstanding presentation from our prominent speakers, who are Professor Alison Hutton from the University of Newcastle, Australia. Hello, Prof. Ellie, are you here?
Hello, yes, I'm here.
Good, thank you. And the second one is Dr. Sentot Imam from Strada Kediri. Dr. Sentot is not here yet. And the third one is Dr. Ken Hock Manho from the Chinese University of Hong Kong. I think Dr. Ken Hock Manho is already here. And the last but not least is Professor Lisa Renwick from the University of Manchester, UK. But Prof. Lisa will join us later. Each speakers will be given 30 minutes and then we will have 30 minutes for question and answer session. For the audience, the participants, you may type your question in the chat room and I will read the question for you, or you may raise hand using a raise hand button if you want to ask the question directly to the speakers. Okay, without further ado, please welcome Professor Alison Hutton from the University of Newcastle, Australia, who will deliver the presentation entitled Nursing Disaster Management, Climate Change, and the Nurses' Role in the Working with the Community. Professor Alison, before Professor Alison present, Dr. Mira will read the curriculum vitae of Professor Ali. Please, Ibu Mira.
Thank you, Dr. Nino. Ladies and gentlemen, I will read curriculum vitae of Professor Alison Hutton. Professor Alison Hutton is professor in nursing and also deputy head of school nursing and midwifery, the University of Newcastle, Australia. Academic qualification began with Diploma of Applied Science, South Australia College of Advanced Education, Pediatric Certified Adelaide Children's Hospital, Bachelor of Nursing, Flinders University, Master of Nursing, Flinders University, Doctor of Philosophy, Flinders University. Since 1996, registered nurse from Women's and Child Hospital Adelaide. From 2017 until now, Prof. Ellison as Professor in Nursing, School of Nursing and Midwifery, University of Newcastle. She has many publications in high-impact peer-reviewed journal. The last publication is about comfort equal nurturing. Young people talk about mental health work design, published in Health Environmental Design Journal. Prof. Ellison as professional consultant and invited speaker from many universities. Prof. Ellison Hutton also obtained many research grants in various research projects, including local and international competitive grants. Prof. Ellison Hutton also as journal reviewer as many international journals. I think that's all about our first distinguished speaker, Prof. Ellison. Thank you.
Thank you, Ibu Mira. Now, please welcome Professor Ellison Hutton. Professor, the Zoom is yours.
Unmute. Hello, I'm sorry, I had to unmute myself. So thank you very much. I'm sharing my slides. Can you see my slides? Thank
Yes.
you. That's lovely. Thank you very much. Thank you, everybody. And thank you very much for having me and inviting me to be with you today. Sorry, I can't be with you there in person, and I hope that you're having a wonderful conference. As you know from the introduction, my name's Alison Hutton and I'm a Professor of Nursing at the University of Newcastle. Today, can I have the next slide, please? Because are you able to move my slides on? Because I can't for whatever reason. I just wanted to show people where Newcastle was. Is it possible to move my slides on?
Do you need help with the slide presentation, Professor?
I can't move it forward.
Okay. Could you
I'm
please
sorry, everybody.
stop the share screen so
Stop
we
the
can
share
help you
screen?
from here?
Okay.
Yes.
Yep. Thank you. Can you please move the slide on? Thank you. Sorry. Oh God, now I can hear myself. I'm just going to lower that down a bit. Okay. So I'm from the University of Newcastle, and as you can see from the map of Australia, Newcastle's just above Sydney. Today I'll be talking about the effect of climate change in Australia, and I'll be focusing on bushfires and discussing the nurse's role in community and individual preparedness. Next slide, please. Thank you. So rising global temperatures have resulted in a number of disasters in many parts of the world. These disasters have a devastating impact on community and the health of residents. Over the past half century, the persistent burning of fossil fuels has released enough carbon dioxide and other greenhouse gases in the atmosphere to trap additional heat. These rising greenhouse gas concentrations have resulted, if you can go back to the original slide, to the introduction, please. Anyway, these rising greenhouse gas concentrations have resulted in the Earth becoming progressively warmer each decade. As a result, worldwide, there have been an increase in variable hydraulic events, for example, glaciers melting, heavy precipitation, general flooding, flash flooding, and coastal floods, and other meteorological events such as cyclones, hurricanes, tropical storms, and sea level rise. Each of these events has the potential to negatively affect the health of populations across the globe. And some degree of climate change is unavoidable, but we must adopt to its associated health effects. If you can go back to the slide previously that says climate change, please, that would be great. No, back, the other way. And one more. And again, thank you. That's awesome. The scientific evidence to support climate change is strong, alongside the link to increasing disasters, yet contentious international political debate persists regarding what actions to take in response. Nurses are well placed to help in disasters. Nurses are the largest health resource, and as such, they are well placed to contribute to disaster preparedness efforts for climate change related disasters. They can help build sustainable communities. They can advocate for more robust environmental health policy and also work towards mitigating exposure to environmental toxins that may threaten human health. Next slide, please. In Australia, flooding is common. However, today's discussion is going to focus on bushfires, even though if you live in Australia at the moment, I should be talking about floods. But the catastrophic, unprecedented fire conditions currently affecting Australia have been aggravated by climate change. Australia's current bushfire risk has been exacerbated by record-breaking drought, dry fuels, and soils. And in addition, bushfires conditions are now more dangerous than they have been in the past. The risks to people and property have increased, and our fire seasons are becoming longer, and therefore it is becoming harder to prevent bushfires, and it's also making fighting fires more dangerous. This means that we already have reduced opportunity for fuel reduction burning. The cost of fighting fires are increasing, and as seasons overlap and fires become more destructive, governments are having increasingly constrained in their ability to share resources. Next slide, please. The nature of bushfires has changed. Bushfire conditions are now more dangerous, and the risk to people and property has increased, and it is expected that extreme fire weather will continue to become more frequent and severe in Australia. Similar to floods, climate change is increasing the severity of bushfires. The burning of coal, oil, and gas is driving up global temperatures, leading to hotter Australian conditions. Since the mid-1990s, Southeast Australia has experienced a 15% decline in rainfall and a 25% decline in average rainfall in the winter months. Across Australia, average temperatures have also increased, leading to more record-breaking hot weather. Extreme fire danger days have increased. In 2020, the bushfire risks in many parts of Australia were exacerbated by drought, dry fuels, dry soils, and increasing heat. Rainfall was also lowest on record, with many parts experiencing very low soil moisture. And these drought conditions means vegetation is more flammable and therefore more likely to support extreme fire behaviour, and also encourages spot fires. Heat is a factor too, both exacerbating dry conditions and enabling sparks to take hold. Next slide, please. In Australia, catastrophic fire rating changes have been in place since 2009. But in 2019, it was the first time we'd ever used them, so 10 years later. And Australia's largest city, which was Sydney, and the greater area was all placed under a catastrophic fire rating. And this was the first time the fire rating had been used. It was also declared over quite a densely populated area of over 6 million residents. And considering that Australia has a population of 23 million, that's quite a large percentage of the population. So in Australia, fires in catastrophic conditions cannot be fought safely. Lives and homes are at serious risk, and it's just making it harder and harder to keep people safe. Next slide, please. So now we're getting to the nursing part. So how do we help in community preparedness? Next slide, please. In disasters such as bushfires, we need to do more than respond. We need to be part of the public preparation for the event. Nurses can contribute to teams that serve to protect the health and safety of the community. Nurses are highly educated, experienced health professionals who are accessible through many settings. and they have a key role in providing information to the public in the form of health teaching. In addition, nurses can direct people to local health resources and provide health wellness information. They can also work with established community non-government organisations to build resilience against known risks, work with families to identify what is needed at an individual and community level to stay safe from fires. So one of the best things that nurses can do is work in areas that are prone to bushfires and work with the community to ensure they have a plan in place to understand what they will do during a bushfire. Next slide, please. So first we need to determine the risk. So from a community perspective, when working with them, we really need to know where we live and what the risk is to the environment we live in. So an example is if you live in the bush, you will need to determine what foliage is around, and you need to understand what foliage needs to be cut back. So if your house is surrounded by parks or grassed areas, you're at risk because embers spread easily. If you live on a hill, you're at risk because fire actually races up a hill. As the angle of a hill increases, so does the risk of the fire travelling. If you live near beach, grassy areas can catch fire very easily. So you need to understand what's around your environment. The 4 basic steps are understanding what to do if a fire threatens your home, prepare your home for bushfire season, stay in touch with bushfire levels or news, and keep any information websites nearby. And my biggest tip is down the bottom of the slide here, to keep a battery-powered radio so you can hear the local community radio without having to rely on electricity. And that's probably the biggest tip for all disasters, is to have a battery-operated device so you can hear any news or any notifications from the government. Next slide, please. So communities need the support of nurses who can contribute to holistic disaster preparedness and recovery, and really work with the community to create a more sustainable future for them. Therefore, you need to be acquainted with the local government resources, the emergency services that are present, the hospitals, community health system, Puskesmas in Indonesia, who are the government officials you need to talk to, what are your associated policies and protocols. And education is also a really important aspect of disaster management, and a large amount of work with the community is to educate families about how to plan and stay safe. So next slide, please. So to do this effectively, we have to use the good old nursing diagnosis. We need to assess what the risk is, and we have to diagnose. Assessment and diagnosis allows us to do a risk assessment and analysis of the environment, and also to really understand what resources are available to us. For example, what has been the magnitude of bushfire damage in the past? What are the strengths and weaknesses of the local community? How did they cope? What can we improve on? Are there established spaces for disaster shelters? Is there a current community plan in place for evacuation? And are there available health resources or community resources to help support the community? And last but not least, what's the current water supply? And again, battery operated radios are a must. And does your area where you live or reside or work have a local information system for locals to access? This is all the kind of stuff that it's important that nurses understand to help their community. Next slide, please. So after assessment and diagnosis, we have risk management. And this allows us to have a structured and logical approach to the identification and management of risks. And it's 101, identify risks, analyse, evaluate risk, treat the risk, monitor the risk, because we need to make sure that we understand whatever we're doing, whether it's effective or not. And we also need to consider what preventive measures that can be taken care of or instigated. Is there an opportunity for collaboration? Can people work together to help and support each other in getting their homes ready for a bushfire? Are there any established community practices or Indigenous practices that we can use to support the community? And lastly, outside times of disasters, it's always really good to know the baseline of the community and how prepared they are for disasters, whether it is actually flood or bushfire, because that's always a really good place to start from. Next slide, please. So when talking to the community about bushfire, there are a number of things they will need to consider, like when will they leave and where will they go? What will they take? How will they get there? Have they got animals, young children, elderly to consider, and do they have a backup plan if things won't go well? Next slide, please. So your role is overarching when helping people decide where they are going to, whether they're going to stay and defend their home or whether or not they're going to go to safer ground. So when people want to stay, have they got appropriate clothing? Is it fireproof? Do all members of the household have a role? Do they know what that role is? Are there flammable items away from the house? If there are gutters, which hold the rain around the house, are they filled with water? If there's any drains, are they blocked with socks or sand? Can you fill any baths or sinks with water? Can you close the windows? Is there a ladder nearby to get on the roof if need be? And are there wet towels or rugs around in internal doorways? And if a family isn't able to be prepared in that way, then it's best that they go to safer grounds. Next slide, please. So just always want to talk about communication when we're talking about disasters. It's always an essential plan of working together. In disasters, we normally work with lots of people that we don't know. But if we are working in the hospital setting, the person that you would normally communicate with would probably be your boss. So you might keep those normal ranks. Also, you might formal and informal communication may happen. You need to work out what's the best way to talk to your community. I always tell people it's good to have pen and paper because we can't always rely on electricity during disasters. So one of your roles as a nurse is to ascertain what is the best method of communication and promote that during a disaster. And part of that also might be having a notice board in a shelter and communicating instructions to people about where they might be able to get medicine or where they might be able to get food or some kind of support. So we need to think about what's the best way to communicate to the population. Next slide, please. So once a disaster has occurred, the next thing that we need to do is ascertain the impact of an event and to establish priorities and identify what the public health problems are and whether or not there are any communicable diseases that we need to consider. So that's another thing to think about. And then next slide, please. We're nearly finished. Chain of command, I alluded to in communication. So next slide, please. Chain of command, it's really crucial that you understand who you report to, who reports to you during disaster. And positions such as triage are normally performed by the most senior person. But if you do end up triaging and you don't feel confident, remember that this is not a competition. In a disaster, you just work to the best of your ability and do your best. And disasters are really busy work environments, so it's really important that you delegate responsibilities to people if you need to. And examples might be asking children to look after animals or older children to look after younger children, asking people to help transport other people in their cars. And it's a great way to get people to feel like they're part of the recovery and they're not so vulnerable. And last but not least, I'll just finish up quickly because I understand that I'm nearly out of time. You may be really confident in your chosen field, but you may not always be ready to deal with the chaos of a disaster. So knowledge, adaptability, familiarity with your local setting, and a compassionate nature are only a few of the qualities that make nurses an essential resource for disaster response. So I just want to thank everybody for having me, and I hope that was useful and you learned something. It was interesting, and I'm happy to take questions. So thank you.
Thank you so much, Professor Alison Hutton, for the very interesting and useful presentation. You have shared your experience in working with the community during the disaster management cycle, from disaster response, and also how to improve the community resilience, and how to work during the nursing process from assessment and evaluation. Professor Hutton, we will have a question and answer session in the at the end of this plenary session. Will you be able to hang in the meeting?
Sure.
Okay, thank you so much. And before the next speaker, the committee will share the certificate of appreciation for Professor Alison Hutton. Professor Hutton, thank you so much for your speak. This is the certificate of appreciation from the committee of the 13th International Nursing Conference. Thank you.
Thank you. Thank you for having me.
Okay, thank you. And the next, I will call Dr. Sentot. Is Dr. Sentot Imam already here? Okay. Dr. Sentot Imam will deliver a presentation entitled Empowerment of Health Workers in Effort to Respond to the Occurrence of Climate Resilience. Dr. Sentot, before the presentation, Dr. Mira will read the curriculum vitae of Dr. Sentot. Please, Ibu Mira.
Thank you. Ladies and gentlemen, I will read curriculum vitae of Dr. Sentot Imam Suprapto. Academic qualification, the first, Faculty of Medicine, Universitas Diponegoro Semarang, Master Program in UNISKA Kediri, Doctoral Program in Universitas Brawijaya Malang. Dr. Sentot Imam active in many professional organizations like IDI, PDUI, Arsada, Persi, Adinkes, IAKMI. Professional history, Head of Emergency Unit at Regional Public Hospital Gambiran Kediri, Head of Division for Family Health at Health Department Kediri City, Head of Division for Empowerment, Social Health and Family Planning, Head of Health Department Kediri City, Director of Regional Public Hospital Gambiran Kediri, Coordinator of Public Hospital in Kediri area, and as a Rector of Institut Ilmu Kesehatan Strada Indonesia Kediri. I think that's all. Thank you.
Thank you, Ibu Mira. Dr. Sentot, please welcome, ladies and gentlemen, Dr. Sentot Imam, Magister Management. Dr. Sentot, your time is 30 minutes. Thank you very much.
Assalamualaikum warahmatullahi wabarakatuh. Honorable Dean and staff in Nurse Faculty, Airlangga University, and my friend. In this great moment, let me give a speech of the topics. It's empowerment of health workers in an effort to occurrence of climate resilience. But let's
say your praise to Allah Subhanahu wa Taala for all the bless with abundance of blessing for head and the opportunity together in this moment. I appreciate the NGU UNER 2020 to celebrate an annual event of Earth Day and on April 22. Ladies and gentlemen, realize it's or not we live in the world depend on the environment. We breathe this air, we drink the water, we eat foods which are planted from our environment, and we eat foods which are planted from
Excuse
our
me,
environment.
Dr. Sentot,
Yes.
do you need help with the slide presentation?
Okay.
Sharing your slide, please.
It's all right.
Do you need help with the PPT sharing? Perlu bantuan untuk share screen, Dok?
Yes. It's okay.
Yes.
Okay. Thank you. My topic is empowerment of health workers in an effort to respond to occurrence of climate resilience. Ladies and gentlemen, realize it or not, believe in the world depend on environment. We breathe this air, we drink water, we eat foods which are planted from our environment. Our environment has a great influence in our life. Our environment gives us life. Good or bad, the condition of our environment will definitely affect our life, even our existence. Our environment is my life. What's happened with my surrounding? Let's close our eyes and remember, fresh air if we breathe deeper and now was gone. Drink clear water once more. This is my problem. And now we are stiffingly hot. Why? Why we stiffingly hot? We see stiffingly hot is what happened. We breathe much more carbon monoxide and pollutant. And the next, because of climate exchange, is culture, industry, season, or the others. Here, those of stiffingly hot, image, disaster, greenhouse gases. An example, we see of the example. Please, the next. The floods often cause damage to homes, to businesses, if they are unnatural floods, plains of a river. The disaster is not to a plan. The next, forest fire. Forest fire is uncontrolled plantation. Forest burning and long dry season. And the next, this is next week, maybe 2 weeks again, is congestion. Oh, no. Before? Or before? Okay, it's good. Disconnection of traffic in Brexit. Situation uncontrolled. And where is the worker, head worker? Where is it? Where is she? Where is he? The worker in the case of congestion? Yeah, my question, your question, where is the helper? The health worker, cadre, and society. Where is it? Where is the helper? And community or public? Okay, next. We must the effort of the health workers, the workers from medical, nurse, midwife, the effort of cadre, UKS from school, Pramuka, Karang Taruna, PKK, Hansip, is NGO, non-government organization, and society, like this at Medsos, Orari, Rapi, maybe Ojek, is head workers. The answer of the question, my question. The next. Nah, climate exchange community gets climate exchange. And the workers to empowerment. To empowerment for what? Ready to rescue. Like this in Kediri. My campus in near of Kelut Mountain. Kelut Mountain like this every 7 or 8 years to damage, to explode, and condition is, the situation is not good, and we must do collaboration, we must do coordination health workers before damage, before disaster, ready to rescue. And we must do simplicity to respond collaboration. The next, okay, coordination in damage disaster, military, policy, PNPB, government organization, and we not forgotten the cadre. Cadre must be training. PLS, basic life support. Cadre must we try and to get to PLS, basic life support, and maybe get the dapur umum, general kitchen, yeah, and health transportation. When transportation is stabil. Now, post from society, 20 hours. to respond. This communication from RAPI. RAPI is organization radio communication atau orari amatir organization, and do not to forget social response. PKK is the and maybe baby to lansia, and maybe an NGO like this Banser Relawan Program. Each social response must be to coordinate. Okay, next. Resilient to rescue leader is head. Individual maybe doctor, maybe nurse, maybe midwife, and community. At the clinic, are you ready clinic or hospital to manage the disaster, to manage the congestion in season or in every years? And we know the government get the open of the mudik. Open of mudik is a culture in Indonesia. We must coordination about health community, and non-health maybe cadre like this, and from student, from younger, from pramuka, ya, and society. Society maybe resilient to rescue in communication, in general kitchen atau dapur umum, ya. And now, next. This is must be try to gather to NGO from campus. Usually the kader, the relawan gets the theory of basic life support. This is a basic trauma cardiac life support is maybe to review to my friend in Puskesmas, in posko mudik, ya, posko disaster, or in the along way Jakarta to Surabaya. It's maybe disaster about mudik. Basic life support. Trainer from campus to maybe police, maybe to kader, maybe to the relawan, and support to technique and like make those in disaster. And the next. If you get you see the picture, we know my children, we know my friend, a little friend. We say, they say about, please don't give an unhappy to the children, to my life. please don't even unhappy to the children. Okay. The next, this is maybe Maisi Matur Suwun. See you again. But nurse is allocation this technique simplicity to basic life support, to cadre, to handship, to police, to military. Yeah, the preventive of disaster, maybe earthquake, maybe disruption of mountain. I am in Kediri with my campus, with my friend in Kediri. Maybe get the innovation to release in climate exchange. Thank you, and matur suwun. See you again.
Thank you, Dr. Sentot, for the thoughtful presentation who highlight the need of lay rescuers from cadre and also volunteer, and the importance of coordination and collaboration between many stakeholders during the disaster response phase of disaster management cycle, and also the importance, the role of nurses to prepare these lay rescuers to help improve the service for the disaster victims. We will present the certificate of appreciation for Dr. Sentot from the committee. Dr. Sentot, thank you very much for joining the 13th International Nursing Conference. And I hope you will join this second plenary session because we will have question and answer session at the end of this session. Thank you so much.
Thank you.
Okay, honorable speakers, distinguished guests, participants, ladies and gentlemen. Now we will have Dr. Ken Hock Man Ho from the Chinese University of Hong Kong. Hello, Dr. Ken. How are you?
Hello. Very good day.
Have a good day for you too. Thank you.
Yeah.
And before the presentation, Ibu Mira will read the curriculum vitae of Dr. Ken Hock Man Ho.
Thank you, Dr. Nino. Ladies and gentlemen, I will read curriculum vitae of Dr. Ken Hock Man Ho. Dr. Ken Hock is an assistant professor and the chief year coordinator of the Master Philosophy PhD program in the Nedersol School of Nursing, Faculty of Medicine, the Chinese University of Hong Kong. Academic qualification of Dr. Ken, Bachelor of Nursing, the Nedersol School of Nursing, the Chinese University of Hong Kong, Master of Science in Clinical Gerontology, Faculty of Medicine, the Chinese University of Hong Kong, Doctor of Philosophy in Nursing, Hong Kong Polytechnic University with award, Faculty Distinguished Thesis Award. Dr. Ho achieved the research award from the Hong Kong Polytechnic University and also from Tuang Wah College. This research area include migrant care workers, older adult loneliness, and qualitative research methodologies. The clinical experiences included geriatric nursing and emergency nursing. Dr. Ho is an associate editor in Nursing Open, reviewer of journal, external advisor for nursing school, consultant of NGO, and also a global burden of thesis collaborator. Dr. Ho obtained many research funds in various research projects and has many publications in high-impact peer-reviewed journal. I think that's all. Thank you.
Thank you, Dr. Mira. Ladies and gentlemen, Dr. Ho will deliver a presentation entitled, "Are we ready to support the well-being of migrant domestic workers? A global health equity perspective." Dr. Ho, the Zoom is yours.
Thank you very much. So I try to share my screen first. So you can see my screen now.
Yes, we do.
Okay, thank you. Thank you very much. Thank you for providing the opportunities for me to present in this important conference. And I am an assistant professor from the Lafayette School of Nursing of the Chinese University of Hong Kong. And today, what I'm going to present is about the well-being of migrant domestic workers. So the topic will be, are we ready to support the well-being of migrant domestic workers, a global health equity perspective? So throughout these years, I researched on various aspects about migrant domestic workers, particularly based in Hong Kong. And there are, in this presentation, I will share with you about all along of my research related to these populations and how to sustain their health and well-being in a global perspective. So first of all, who are the migrant domestic workers? This term may be very familiar to those living in the Asia, but it may not be so familiar for those living in, for example, Northern America or Western Europe. So here, let's have a brief understanding of who they are. There are a group of international migrants who migrate from their home countries to another host countries to take up the household work within an employment relationship. So most of them, they will do the job about cleaning, cooking, and nowadays a lot of migrant domestic workers are joining the workforce in caring for older adults. And so usually, in fact, this phenomenon is not new. And in 2000, it was talked about as a 3Cs phenomenon. We talk it as cooking, cleaning, and caring. And more recently, we identified that migrant domestic workers is basically a group which is highly vulnerable in their well-being and health in the host countries. And some more negative terms were found from literatures, which can be grouped as 3Ds, dirty, dangerous, and demanding. So these are not talking about the personality or characteristic of migrant domestic workers. The 3Ds are talking about the job nature of migrant domestic workers, that is to highlight their vulnerable status around the world. So let me show you something. So for migrant domestic workers, basically, there are around 11 million of migrant domestic workers globally in 2015, and absolutely this number is more than 11 million nowadays. And according to their distributions, they are mainly distributed in 3 major areas. They are in, a lot of them are in Arab states, and also in Asia, particularly the Eastern Asia and also the Southern Asia. So you can see that on the right-hand side, there is a survey done recently to show that basically the number of migrant domestic workers in Hong Kong, Taiwan, and Singapore, they have been increased for a lot of years, at least for more than 20 years already. And it is because of the aging population in these areas. So basically, according to my research, we understand that population aging is a global phenomenon. And we know that in order to sustain the family health of the host countries, many of them will hire migrant domestic workers, particularly from two countries, which are Indonesia and also Philippines. And they hire the workers to take care of the older adults in their family household. And these kinds of caring or these kinds of ideology, nowadays they are termed as the liberal familialism. Why? Because particularly you can see that most of the migrant domestic workers are distributed in Asia, because Asia has a heavy culture of familialism. But with the changing population structure, for example, the increasing number of nuclear family and the decreasing number of offsprings in every household, family itself is no longer able to take care of older adults in the family. But however, the problem is that Asians, they highly value about aging in place, particularly aging in their household. And so the problem is that they need to outsource some of the caring work in order to maintain their filial piety or to protect their older adults to be able to aging in the community. So the trend is increasing, and we can see that the number of migrant domestic workers in all these host countries will continue to rise, given the improving economy in a lot of Asian countries, and also the population aging will drive the demand for migrant domestic workers. So in fact, according to past research by a lot of different scholars, and including me, we identified that migrant domestic workers, in fact, contribute a lot to the world, I can say, to the world, because they basically support the well-being of different people, particularly for older adults or the children, even though the employers in family households. For example, in Singapore, in 2013, you can see that basically migrant domestic workers can moderate the impairment of physical, memory, and behavioral functions of older adults. And also they allow the flexible day-to-day schedule of family caregivers. So you can see that the family caregiver burden will largely decrease. And in Hong Kong, that is in my hometown, my research showed that migrant domestic workers, they somehow can develop a very close relationship with older adults. So migrant domestic workers are not only satisfying the instrumental care for older adults nowadays, somehow they also develop some kinds of emotional bonding with older adults as well. And as such, my recent research also showed that for Hong Kong older adults, if they are living with migrant domestic workers, Hong Kong older adults will demonstrate, or there is an association that Hong Kong older adults will have a lower loneliness level than those not living with migrant domestic workers. And so that's why another further research further showed that The dyadic relationship, that means the relationship quality between older adults and migrant domestic workers, is basically associated with lower level of loneliness of older adults. So this new research show that migrant domestic workers, they are very important for the psychological well-being of older adults, not just for taking care physically for older adults, but they somehow have some psychosocial benefit for older adults as well. And again, migrant domestic workers were able to moderate the caregiver burden of spousal caregivers. It is important because nowadays a lot of older couples, they are living alone in the household, and there may be migrant domestic workers to take care of them so that the old caregiver burden will be relieved. And in Taiwan, there was a survey done and just have comment that 91% comment that migrant domestic workers provide proper care for people who need it. And for sure, they reduce the employer's mental stress from caregiving and allow the employers to work outside the home. So globally, we also see that migrant domestic workers are very important for the economy of host countries because they allow family caregivers to continue to participate in the labor force to support the family and also support the economy of the host countries as well. And they also reduce the employer's domestic work. It is for sure because this is their functions for employers as well. So the question is that migrant domestic workers demonstrate a lot of contributions to the world. However, it seems that we do not have much concern about the right, particularly for this conference, the rights to health for migrant domestic workers. Why do I say so? You can see there are a lot of vulnerabilities identified for the group of migrant domestic workers. And recently, I conducted a scoping review on the vulnerabilities and health status of migrant domestic workers. And according to my scoping review, there were 4 categories of stresses or vulnerabilities faced by migrant domestic workers. A lot of them face the problems of abuse and exploitation. And you can see that the scoping review identifies some countries with some quantitative data survey. For example, around 80% of them were subjected to sexual abuse in Israel. And you can see that more than half of them were subjected to exploitation. And abuse is basically very common around all the host countries employing high domestic workers. And in the Middle East and Malaysia, you can see that physical harm and maltreatment account for a significant percentage as well. And as well as in my hometown, Hong Kong, you can see according to some survey, there were more than 20% of migrant domestic workers suffered from physical abuse and verbal abuse. And for migrant domestic workers, why do they endure such kind of abuse? Because the basic, very primary reason is that they will face financial hardship if they quit their job. There is a quote from migrant domestic workers that I'm so stressed, and actually I was on sick leave for 12 days because of the stress. But what I keep worrying is about my family, that if I lost my job right now because I know I'm not happy with it, if I leave this job and I cannot find a job tomorrow, then I lose pay. It is well known that migrant domestic workers, they send remittance to support their family in their home countries. And it is also well known that the salary provided by host countries is usually 3 times to 4 times more than the earnings in domestic earnings in, for example, in the home countries. So it is very important that they are bound to support financially to their home families as well. However, when they are living in the host countries, most of the migrant domestic workers are suffered from very limited health literacies, and they are basically marginalized from health and social care system of the host countries. For example, in Cyprus, you can see that there are more than 70% of migrant domestic workers suffering from health illiteracy. And more than 10% of them did not receive or adequate medical care from the host countries. And this is only one example of data that I showed you. And particularly for psychosocial aspect, migrant domestic workers suffer from social and cultural isolation. For example, 48% of migrant domestic workers expressed social isolation. And the major contributor of these social isolation are basically the employer. Because employers are very powerful, and sometimes they can forbid migrant domestic workers to have social connections, and the long working hours and lack of alternative co-workers as well. And all these vulnerabilities basically are also confirmed or highlighted by the UN Women as well. So you can see that they are highly subjected to social isolation, abuse, and limited access or even no access to healthcare in host countries as well. So particularly in order to sustain the health and well-being of migrant domestic workers, we have to target the phenomenon that we identified. There is a particular phenomenon identified called the healthy immigrant effect. It is basically a phenomenon talking about a progressive health declines experienced by migrant domestic workers in host countries after arriving in their host countries with excellent health. So why do they experience decline of health in their host countries? Because of the nature of the domestic work. That is usually long working hours, very demanding, and particularly for the live-in arrangement, contribute to their psychosocial isolation as well. So all these create health inequalities of migrant domestic workers. For example, this is a survey done by an NGO, the Vision for Migrant Workers in Hong Kong. It is a survey particularly to understand the problems faced by migrant domestic workers caring for older adults. And you can see that a lot of them, they experience lack of sleep, and usually they do not have a regular meal time. And all these, we call it everyday working situation or habit, contribute to a lot of different kinds of physical problems listed here. And you can see that most of the problems are chronic, fatigue, headache. And you can also see there are also some mental health problems, depression, anxiety, and body pains as well. And so you can see migrant domestic workers are suffering from both physical and mental health issues in host countries. And according to my scoping review, you can see particularly they highlight cardiovascular disease, for example, hypertension, and migrant domestic workers suffer from respiratory disease and diabetes mellitus. And particularly in Malaysia, 3.1% of migrant domestic workers suffered from foreign pregnancy as well. And usually, migrant domestic workers, they do have the problems of fatigue, poor sleep, and chronic pain. And these three problems are basically also associated to their mental health problems, because these are also the somatization of mental health problems for migrant domestic workers. But unluckily, I cannot identify any systematic survey data on the physical problems of migrant domestic workers. That means that internationally, we still lack any quantitative survey data to quantify the prevalence of physical problems of migrant domestic workers. And the nature of caring for older adults is particularly vulnerable because of the heavy emotional toll when they take care of older adults. And this is a paper that I published several years ago to highlight the emotional labor bared by migrant domestic workers. For example, they are unable to express their emotions because for Chinese, it is not good for migrant domestic workers to cry in front of the employers. So they have to control their emotional express and to bear the negative emotions without ways of ventilation. On the other hand, because as I said before, migrant domestic workers develop very strong and close bonding with older adults. So these kinds of strong bonding also become some kinds of burden for migrant domestic workers as well, because they will worry about the well-being and the health of older adults that they care. And that's why with the emotional toll and all the vulnerabilities that we identified, we can see that a lot of migrant domestic workers, they suffer from different types of mental health or emotional distress problems. For example, in different countries, there are a lot of data showing their problems, for example, feeling stressed, and even in Nepal, more than 60% of them have a psychotic episode. And for more common indicators, for example, depression and anxiety, there are more than 10% of migrant domestic workers suffering from these problems. And a very recent trending global health threat is the loneliness. And you can also imagine that basically more than 20% of migrant domestic workers, they suffer from loneliness as well because of the homesickness. And we now understand basically migrant domestic workers, they demonstrate poorer health and well-being than general population. And the reason, apart from their particular vulnerabilities, and other reasons may be they do not have many resources when they tackle any problems in the host countries. My scoping review were only able to identify 2 resources for migrant domestic workers, which are social networks with friends and families and participating in religious activities. So having networks with friends and family allow migrant domestic workers to share information and advice, and also allow them to engage in religious worship together and getting emotional comfort from each other. And participating in religious activities is basically a popular strategy employed by many migrant domestic workers. They may sing prayer or reading a Bible together, but you can see that more than 50% of Filipinos they read Bibles. However, the study also showed that reading Bibles does not have a significant effect in relieving the stress of migrant domestic workers as well. So the scoping review identified that, in fact, these 2 resources are not provided by health and social care professionals in the world. These 2 resources are basically the personal resource of migrant domestic workers. So my scoping review basically suggests that we do not have structured or formalized health and social care professionals to cover the health and well-being of migrant domestic workers internationally nowadays. And recently, the Wellcome Trust from the UK support my project to do another scoping review about is there any possible solutions or strategies to support the mental well-being of migrant domestic workers so that it is a sustainable solution. And according to the scoping review, we identified that migrant domestic workers, they make use of peer support very good, particularly in the modality of providing mutual aid support to each other. And the mutual aid support basically serves the function of providing emotional support, informational support, and instrumental support. And there is also another pioneer study in the Singapore that they are trying to train migrant domestic workers to be paraprofessional. That means to equip them with some degree of professional skills in the counseling, so that these kinds of trained migrant domestic workers, they can be peer leaders to support the mental well-being of other migrant domestic workers. And we find that it is optimistic and feasible for us to train migrant domestic workers with some professional skills, for example, with the cognitive behavioral therapy knowledge. And most of them demonstrate significant improvement in mental health literacy as well. And encouragingly, 70% of the trained migrant domestic workers, they were willing to be peer counselor in the future as well. But there were also barriers identified in the two types of support. The first one is basically in helping peers by mutual aid, there is a problem. We term it as a contagion of emotion, or in psychology term, it calls a transference of emotion. That means the negative emotion may transfer from one peer to another peers, and this can be a problem without professional training. And so the negative emotion can spread among the groups of migrant domestic workers. And also there may be also stigma between the members as well. And particularly for those migrant domestic workers, if they are more wealthy, or even though they have the permanent residence in some countries, for example, in Canada, migrant domestic workers may be able to get permanent residence as well. And also, because most of, as we said, migrant domestic workers are subjected to isolation. So they may not be able to get a mutual aid as well. And for paraprofessional trained peer support, the problem is that most of the migrant domestic workers, they are unavailable for the training during their working days. And there is also a problem that particularly I find it in Hong Kong, that we do not have a group of culturally competent healthcare professionals to work with migrant domestic workers. And also migrant domestic workers, some of them will stay, have a very short stay in the host countries because of changing their job. And the content of the professional training may also be too heavy for some migrant domestic workers as well. So basically, I recommend that providing peer support training to migrant domestic workers can be a structurized and feasible interventions to try in different host countries. And of course, the effect is still not yet known. And in the future, we will need more rigorous research. Particularly, I will say we need to work with migrant domestic workers. So participatory action research will be highly recommended. And we also have to nurture a group of culturally competent healthcare professionals and social care professionals to understand the culture of migrant domestic workers in order to work with them and to promote their health and well-being as well. So to conclude, migrant domestic workers is a highly vulnerable groups and marginalized group of workers. They have very limited access to health service, and they are suffering from both mental and physical health problems. And we identify a particular phenomenon of healthy immigrant effect as well. And so in order to support them, the first step I suggest will be to provide peer support training to migrant domestic workers in host countries, so that the trained migrant domestic workers, they can be a bridge between formal health and social care service and other migrant domestic workers in need. So thank you very much. It is the end of my presentation. Thank you.
Thank you, Dr. Ken Kok Man Ho, who highlight the importance of peer support for the domestic migrant workers. And we would like to present the certificate of appreciation from the committee for Dr. Hook Man Ho, and I hope you will still join the plenary session because after Prof. Lisa, we will have question and answer session. Dr. Ken Hockman Ho, this is your certificate of appreciation, and thank you so much for joining the 13th International Nursing Conference. Thank you once again.
Thank you.
And now we come to the last speaker from the University of Manchester, the United Kingdom, Prof. Lisa Renwick. Welcome and very good morning for you, Professor Lisa.
Good morning. Good morning. It's very early here.
Yes. Sorry to keep you rise in very early morning.
That's fine.
Professor Lisa will deliver a presentation about her systematic review of mental health literacy and positive mental health in low and middle income countries. But before that, Dr. Mira will read the curriculum vitae of Professor Lisa Renwick.
Thank you, Dr. Nino. Ladies and gentlemen, I will read curriculum vitae of Prof. Lisa Renwick. Prof. Lisa is senior lecturer in mental health nursing, Division of Nursing, Midwifery and Social Work, University of Manchester. Her academic qualification began with diploma in nursing studies, mental health nursing, postgraduate training, psychosocial intervention for serious mental illness, Bachelor of Nursing, clinical nursing in Dublin City University, Dublin, Doctoral of Philosophy, University College Dublin, and the last 2019 finished postgraduate certificate in higher education, University of Manchester. Since June 2001, as registered nurse in mental health. Prof. Lisa has many publications in high-impact peer-reviewed journals and also obtained many research grants in various research projects and many awards. Prof. Lisa as journal reviewer of many international journals and as editorial board membership Journal of Psychiatric and Mental Health Nursing. Prof. Lisa also obtained many research grants in various research projects, including local and international competitive grants. I think that's all, Dr. Nino. Thank you.
Thank you, Dr. Mira. And Professor Lisa Renwick, would you like to share your own presentation or do you need our help?
Let me see if I can share it. Hang on. Just give me one moment.
Sure.
Can you see that?
Yes, we can. Okay, Professor
great. So
Lisa, the Zoom is yours.
Great, thank you very much. I'd like to say a big thank you to the committee for inviting me here this morning to give this presentation. I'm really pleased to be here. I've put my Twitter handle here. I'm not sure if anybody uses Twitter, but please feel free to tweet any of the slides throughout the presentation. I'm more than happy for you to share them or in other social media networks. So I'll begin. So the objectives of this presentation are to tell you a little bit about two interrelated systematic reviews that we completed recently around mental health literacy and positive mental health for children and young people in low and middle income countries. So to start with, I'm going to describe the burden of mental illness in low and middle income countries, just to give you an idea of why we would need to look at mental health literacy. And I'm going to follow that with describing the reviews, the outcomes and our findings. And then I'll describe some of the ways that we could enhance mental health literacy and develop research to develop community platforms for intervening in and for creating health promotion opportunities. So this is this gives you some kind of an idea of the burden of mental illnesses in disorders across the world and globally. So about 258 million dailies are attributed to mental illnesses throughout the life course. Now, dailies happen at any time in life, but actually the highest burden of mental illness is during adolescence and early adulthood, as you can see from this graph here. That this orange peak gives you some kind of an idea of how many disorders affect youth. So it's quite a substantial problem. So 20% of adolescents between the age of 13 and 18 live with a mental health condition. Suicide is the third leading cause of death among young people aged 18 to 24 or 10 to 24. And 50% of all lifetime mental illnesses begin by the age of 15. And this portends a poor outcome over the lifespan. If you have an earlier onset of illness, you're more likely to have a more severe trajectory. So this gives us some kind of an idea of why we would want to address mental health problems in children and adolescents. It needs to be addressed, and it's an imperative of the UN Sustainable Development Goals for 2030. So you probably know about the treatment gap, the well-publicized treatment gap. Some people say it's around 90%. And what that means is that in low and middle income countries, people who have mental illnesses, about 90% of the people who have mental illnesses do not actually receive any treatment. That happens on a global scale. I think it's about 35 to 40% in higher income countries. So there's a high level of under-treatment of mental illnesses globally, but it's particularly pronounced in low and middle income countries. And 3/4 of the global disease burden occurs in LMICs. Indeed, suicide, 79% of suicides happen in low and middle income countries. And one of the greatest problems one of the greatest issues that drives this problem is that there's a smaller proportion of the health budget is spent on treatment and prevention. So it's about 1.9% of GDP, whereas in higher income countries, it can be anywhere from 6 to 10, 12%. So this is a perfect storm, really. So a higher overall burden of disease and lower availability of human and financial resources makes it difficult for people to obtain effective treatment for their mental health problems. So in terms of strengthening mental health systems, you can see that there's many ways in this diagram. There's many ways that can actually be, mental health systems can be strengthened, from financing and providing human resource to enhancing mental health service delivery, providing adequate surveillance so we know how many people experience problems and how much disability there is, and providing some sort of assessment of quality by evaluating care and then by reforming it. But one of the major issues around inequity is that access to care is not just determined by the way that we provide services, it's also determined by how people view those services and how they view mental illnesses. So a big part of trying to strengthen mental health systems and create demand for mental health systems is about addressing people's mental health literacy and what they understand about mental illnesses. So what is it that we mean by mental health literacy? So one of the most common definitions is by Anthony Jorm. I'm sure some of you are aware of this. He's a a psychiatrist, I think from Melbourne, and he writes extensively about mental health literacy in children and young people, particularly as a way of helping people to understand when they have a problem, when to get effective treatment, or when to advise others to get effective treatment. And this has, been developed into mental health first aid so that the public can be educated about how to access mental health services and how to identify if there's a problem and if that problem is different from normal functioning. Recently, definitions of mental health literacy has included attitudinal factors that influence whether one will seek help or not. And the reason that this has been included is because it's now being understood that if you have knowledge about mental health problems, it doesn't necessarily mean that you will seek help, because you might have a negative view of health services. You might have a negative view of people with mental illness, and we call this stigma, obviously. So the mental health literacy framework now comprises recognition, the ability to recognize specific illnesses, a knowledge of how to seek information, all of the aspects and the characteristics of mental illnesses, what causes mental illness, what are the risk factors, how someone can get help, self-treatment for minor, mild to moderate symptoms, and their knowledge of what professional help is available and whether they should go to a psychiatrist, whether they should go to a Pusgesmas or a primary care centre, and then the attitudes, so the attitudes that influence what they think about mental health problems. So I'm hoping this works. I want to show you a little video, but one of the things that's been developing in the world of mental health literacy is including how people obtain good mental health themselves without seeking help from mental health services. And I want to show you this video because it explains very well what we're thinking about when we're thinking about the components of mental health, because mental disorder only happens to a small number of people in the population. But people can have mental health problems in response to life stressors. They can have mental distress in response to what's going on around them, daily hassles, or they can be, functioning pretty well. So let's fingers crossed and see if this works.
Sorry, Prof. We cannot see the video yet.
Okay, let me see. Can you hear it?
Yes, we can.
All right, let me just see if I can stop share and then start share again. Thanks for letting me know. Apologies about this. I wasn't sure if it was going to work or not. There we go. Now let's see if this works. Hopefully it will. Can you see it now?
Yes.
Can you see it now?
Yes, yes.
Oh, brilliant. Thank you so much. Thanks for bearing with me.
But the sound, we cannot hear the sound. No.
Oh, now you can't hear the sound.
Yeah.
Oh, this is really not working, is it? Shall I just move on? I think if the video is not working, that's okay.
Yes,
because
please just
yeah,
move
it's,
on. Yes.
yeah, because it's really only to describe what we mean by different mental health problems. Play from current slide. So yeah, so what we mean by different mental health problems, and mental health literacy is now taken to include whether people have the internal resources in order to, can you see this screen now? It isn't working at all.
Not yet.
Sorry, 1 second. There we go. Yeah, so now you should be able to see that.
Yes, we can now.
Yeah, thank you very much. Thanks for your patience. There's always technical glitches, I find. I'm not very computer savvy. So yeah, so what we mean by mental health in general is that we see these particular aspects in this triangle as components of mental health. So a small number of people will have mental illnesses and require professional treatment, but quite a few people with mental health problems won't need treatment. So we're including in the mental health literacy concept how people access their own social supports, or how they use their own internal resources, or the problem-solving skills that they have in order to manage their own mental health problems. So I'm just going to start with the first study. So in view of the fact that mental health problems are, happen quite widely, and there's quite a lot of different things that we understand about mental health problems, we undertook to do a review of what children, young people understand about mental health, and whether they're able to correctly identify the aspects of their mental health, whether it's a priority for them. Because I think we often assume that they understand the same language that we do, but they don't necessarily. So we did a comprehensive search of diverse academic literature using rigorous methods to identify and synthesize empirical research conducted in low and middle income populations that examine child and adolescent perspectives of positive mental health, beliefs about factors that hinder and facilitate mental health, and well-being and self-help strategies. So we identified 20 papers from our review, and what we found was once we analysed the data using a narrative synthesis, there was both quantitative and qualitative research. We found that some of the most common components of mental health from children and young people's perspectives were optimism, having a positive outlook, self-agency, being able to make one's own decisions about their own lives, daily life functioning, so having the capacity to manage on a daily basis and to plan their own activities, and morality. So there was an element of morality, and I'm not sure that we see this in high income countries, but in morality was really about religion and about doing good in society. So that's what people took to mean mental health. We asked them about their risk factors for mental health and well-being, or not when we asked them, but when we asked the literature about the risk factors for mental health and well-being, we found that these were the four components that were, or the four themes that were quite relevant. Interpersonal relationships, were a source of support, but also provided quite a lot of stress. So fighting or being bullied or being teased in class were significant issues. Family conflict was a significant issue, and we found that family conflict seemed to relate to, disagreements around romantic relationships, disagreements around academic work, and roles and responsibilities within the house, and particularly for females who might have more kind of roles and responsibilities, looking after younger people or younger siblings in the house. Academic pressures were quite at the forefront, but we found fewer societal pressures. People didn't, children, young people didn't demonstrate an awareness of these and, as affecting their mental health. When we asked them about self-help strategies, these were quite limited in how it was researched, and they seemed to talk a lot about distraction techniques, so listening to music, being alone in their room, or reading, doing activities that would take them away from any kind of negative emotions, and also leveraging social support. And this was an important one because they leveraged different social support based on the type of problem that they had. So they potentially go to a peer for to discuss things about romance, but whereas they would go to a parent to discuss things about academics, and those are just examples. So moving on to the second study, and this was a wider study of mental health literacy and what people thought about, about mental health. Again, we comprehensively searched for and synthesized evidence about knowledge, beliefs, and attitudes to mental illness in low and middle income countries. And we found 58 studies, and this represented a disparate and a wide variety of different types of research. And the data very much varied in quality. So in terms of the ability to recognize mental illness, we found some very interesting findings here. So when people were measured on their general mental health literacy, that was quite poor. About 50% of any of the samples that were included had a good level of knowledge. So that meant that about half didn't. We found if they were asked to identify features of mental illness, this was quite poor. So this ranged from 1.5% of populations to almost 50% of populations were adequately able to recognize the features of and the characteristics of a mental health problem. But illness recognition, when they were presented with vignettes, was varied. So it was really high in places like Sri Lanka, India, but only 50% in Iran, and less than 5% in Nigeria. So this demonstrates a high variability in whether in countries about whether young people are able to recognize mental illness. And I should just say that this refers only to depression. We had very few studies that looked at other mental illnesses, and only one that looked at psychosis. Young people in included studies, there was a small number who already had mental health symptoms. These were measured, but they weren't clinical samples. And they had poor ability to recognize it in themselves, which is really important for self-labeling, because this is one of the key factors in actually, driving a response, or, to seek help, being able to label the symptoms in yourself. So that was a very interesting finding. And we did find that comparisons between countries regarding knowledge and treatments found no differences in literacy levels between high and lower income settings. But again, this was under-researched. Knowledge of causes of risk factors. There was strong evidence for specific misconceptions about the origins of mental illness in several studies. Quite a few mentioned that they believed mental illness was caused by a weakness of character. Immoral behavior was a strong theme, and that any kind of wrongdoing could bring on mental illness through a variety of different sources that were related to religious, spiritual, and supernatural explanations of mental illness. So things like punishment for sin, or a test from God, or witchcraft or wizardry caused the mental illness. And then in some studies, the young people believed physical illnesses were mental illnesses, or they were getting confused about them. And these are the physical illnesses that were cited. So in terms about knowledge and beliefs about self-help and professional help, self-help, people cited some very proactive strategies that include obtaining practical advice from other people, cognitive processing of stressful events. So, taking time to process what had happened. And then, as I said, proactive strategies such as, self-help books, increased physical activity, avoiding illicit and mood-altering substances, and taking vitamins. And interestingly, in some studies, in one or two studies, I think young people believe that taking vitamins was better treatment than antidepressants for depression. In terms of professional help, 40 to 75% of survey cohorts believed that mental illnesses were treatable by health professionals, which is encouraging. But when asked to identify health professionals, these were in the minority that were identified. And there was strong evidence, very strong evidence that there was a lot of value attributed to religious and spiritual leaders and traditional healers, which is probably no surprise to you, actually. And in terms of the factors that influence recognition and help seeking, stigma came out as quite a strong influencer of their views about mental health problems. They were significant and shared by large proportions. And self-stigma was determined the strongest predictor of willingness to seek help in exploratory models, including literacy, mental health status, and help-seeking attitudes. But this was under-researched, and we only found one study that explored this adequately. Again, poor recognition of mental illnesses influenced help-seeking, but evidence was limited. And none of the studies that we included measured actual help seeking. And I think this would reflect the wider literature that when they're looking at evaluating help seeking and mental health literacy, there is a tendency to look at whether somebody says they would help seek, sorry, but not whether they actually have looked for help. So it's all quite hypothetical. So in summary, just to draw together what we found from both of those studies of positive mental health and mental health literacy, we think that there's evidence growing that children and young people can identify relevant aspects of positive mental health, as we saw in the original slide. You know, things that were important were positive views, positive outlook, having positive interactions with other people, maintaining good functioning throughout life. So we think that people are able to recognize that, and that's really important for developing health promotion interventions, because it needs to be infused with what people think are comprise mental health problems. In terms of mental health literacy, we found this was complex and multi-layered. And we found that there was quite a lot of information that was relevant here, and it was really difficult to synthesize. But one of the key issues was that stigma was strong, and that confidence in healthcare professionals was low, even when it was considered a valid route to treatment. So these are really important takeaway messages for how we manage, how we inform kind of mental health literacy programs, that we need to kind of destigmatize how people see mental health problems. And we need to, I think there's a real value in potentially working with traditional healers, because they're very important sources of help for people. So further research, I think, is needed to understand literacy in relation to help seeking. As I mentioned, help seeking is not often measured in an adequate way. And we do need to know about stigma and the effect of stigma on help seeking. Other research shows that community interventions to target stigma are not very effective. And this is really important, because massive campaigns that have been conducted in the UK have not been found to be effective to reduce stigma. They've increased knowledge, but not reduced stigma. And we need to look to other methods of doing that. And I think social contact interventions, so peer interventions, can be really, really helpful in demystifying mental illnesses for people on the ground. So novel research is required in this area, and potential targets are social contact, as I've said, and kind of drawing on social networks, because these are really important in low middle income countries, so people do leverage support from their social networks. And again, traditional healers must be included in interventions. Collaborative approaches should be identified to develop mental health literacy programs, and this is a very, very important target. So just to recognize the team, so some of this research, or some of the wider research that we did, was funded by the Medical Research Council and the team that wrote the paper here, but we had a wider team that included a lot of people from Indonesia, and the team was, you know, made up of University of Manchester, Ministry of Health in Indonesia, and some members of UI, and just to recognize their input. And thank you.
Thank you so much, Professor Renwick, for
Thank you.
sharing your interesting study regarding mental health literacy and positive mental health and well-being in low and middle income countries. Now we would like to present the certificate of appreciation for you from the committee. Professor Renwick, this is your certificate, and thank you so much for attending the 13th International Nursing Conference. And please stay in the Zoom because we will have a question and answer session. So, ladies and gentlemen, thank you very much for all presenters for their informative and interesting presentation. Now we will have 30 minutes question and answer session. And we already have 5 questions. 3 for Professor Alison Hutton from Australia, and 1 for Dr. Sentot, and 1 for Dr. Ken Ho. Okay, Professor Professor Alison, are you still here? Yes, you are here. Professor Hutton, you have 3 questions from Timor-Leste and 2 from Indonesia participants. I would like to read the question that is in the chat room. The first one is, how can the nurses to make coordination and briefing for the community to guarantee they are prepared to manage the effect of climate change for community health in Australia? Professor Hutton,
Yes.
you have 3 questions from
Oh,
the
okay.
participants.
Yep.
Let me just summarize the question. The participants would like to know how the nurses prepare the community to manage the effect of the climate change and during the disaster.
How they'll manage.
And
Okay, sorry. Yep.
okay, the question is how nurses can help
Sorry,
the
I've
community.
got noise in the background, so I'm finding it a bit hard to hear. So I'm sorry. So how nurses will manage climate change in the community?
Actually, the question is in the chat room.
Okay.
It's from Domingus, Priyo, and Liana.
Just have a scroll.
So the first one is how nurses can coordinate and prepare the community to guarantee that they are prepared to manage the effect of climate change for community in Australia. Your microphone is still turned off, Professor.
There's a Can you hear me now?
hear because the background music is very loud. No, it's still mute, Professor. Okay. I think we are going to Dr. Sentot first. This is a question from Domingos from Timor-Leste. The question is, what real point activities to highlight from leader in healthcare, health area, and community to make preparation to be respond to disaster if done in your zone, especially in Indonesia and generally. Dr. Sentot, are you still here?
Maybe I answer this question. Maybe to part. The first step is to the leader. The leader must be identification causes, eruption from the mountain, flood of the river, or burn of forest, or in the etc. in decision is a culture is mudik. Like this is mudik. Like this mudik is in Indonesia, in India, must be identification. Where, when, what. Okay, it's like this. 5 to W and 1 of H. And the second step is in the potential of disaster, maybe must the human resources and the part of the installation like this to have installation like clinic, puskesmas, or hospital. And the step 3 is third step is communication among in location in transportable on in center of helper, and maybe in the first for the leader and the communicate and community must be to mapping the power of cadre and maybe yes, the power of cadre and the skill of the cadre, and maybe in the second step is the first is mapping, and the second is a coordination and collaboration with NGO or general government organization. Maybe it's okay, yeah. In Kediri like this, in near of Kelut Mountain, eruption is maybe every 8-10 years. And my campus is ready to rescue the disaster. Thank you.
Thank you, Dr. Sentot, for your prompt answer. This is the answer from Professor Alison Hutton. So the answer is nurses need to work from the baseline of the community and work with the community to understand their needs. Yeah. And now we go to questions. For Dr. Ken Ho, you have 2 questions. The first one is from Melinda. the question is there a special training program for nurses before they may help migrant workers with problems? And that is the first one. The second one is the migrant workers may experience various problems. Are there any global guidelines that can be used as a reference in dealing with migrant problems?
Oh, thank you. Let me answer the first questions first. For the unpleasant events to migrants, okay. Unfortunately, according to my best knowledge, there are not any special training program for nurses nowadays to handle the problems of migrant domestic workers. And there were not any structured interventions for nurses to equip nurses to handle problems of migrant domestic workers, particularly getting familiar with the culture of migrant domestic workers. So here there is a big training gap and service gap that we can target internationally. Particularly migrant domestic workers are very popular nowadays. And then the second question will be from Yuri. Okay, migrants may experience various problems, global guidelines. Okay, so unfortunately, there is also I was unable to identify any so-called global guidelines for handling the health problems of migrant domestic workers. And I guess it is also very difficult to have universal global guidelines because the situation of different host countries are very particular. And particularly the legal systems in handling the problems of migrant domestic workers are very particular, and their eligibility for migrant domestic workers to their health and social care problems are also very different from one country to another countries. So it is more effective to think about how to work with the consulate of, for example, of Indonesia or Philippines in host countries to develop a basic system to handle migrant domestic workers with physical and mental health problems. So my answer to both questions is no. Thank you.
Thank you, Dr. Ken. And the last question for Professor Lisa. The question is, how is the model approach that can help to overcome adolescent mental problems that can increase mental resilience in adolescents?
Okay, thank you for that question. It's really interesting. I think one of the important things to say is that, you know, if you're looking at mental health problems, we're always going to have a number of people, young people who need professional help and who need professional treatment. And it's important to have the pathways in place to do that within any of the settings that young people are in. But in terms of enhancing resilience, I think that one of the things that I've talked a lot about in the literature is taking whole school approaches. And that means incorporating every element of the school, not just the curriculum, but all of the activities that surround the school to promote mental health and taking all of the opportunities to promote mental health. So a lot of the literature from reviews state that when you take whole school approaches, they're more effective. So there's a really good review, it's a little bit old now, about these approaches in mental health literacy by Margaret Barry, I think. And then there's a more recent review in 2018, which talks about resilience that I think is worth looking at. I can put it into the chat for you. But I think the focus is very much on whole school approaches and not just having one particular module or class within the student's day. It's about promoting mental health across the board. I hope that helps answer the question.
Thank you, Professor Lisa. Actually, Professor Alison still have 2 questions, but I think Professor Alison Hutton is unable to answer the question. So, ladies and gentlemen, we finally come to the end of the session. And before the end of the session, Dr. Mira will read the conclusion of the plenary session.
Thank you, Dr. Nino. Ladies and gentlemen, I will read the conclusion for this plenary. From Prof. Alison can be concluded, nurses contribute to disaster preparedness effort, build sustainable community, advocate for stronger environmental health policies, and work to reduce exposure to toxin can be threaten human health. Communities need support workers who can contribute to holistic disaster preparedness and recovery and work to create a more sustainable future for them. Communication is an essential element of disaster planning and response. From Dr. Sentot can be concluded, climate change causes many problems in health and well-being. The effort of the health worker, cadre, and society are needed. Empowerment is important thanks to ready for rescue. Need coordination and collaboration from multi-sector, such National Disaster Management Agency, military, police, cadre, and society. From Dr. Ken can be concluded, migrant domestic worker protected the well-being of older adults and employers. Migrant domestic worker vulnerable include work-related harassment and exploitation, financial difficulties, poor literacy and accessibility to health services and health insurance. Peer support to mental health of migrant domestic worker can be done with mutual aid and peer support trained by professional as well as barrier to peer support. Peer support training can be considered and possible effective for supporting the mental health of migrant domestic worker. And the last from Prof. Lisa can be concluded. Mental health literacy combine knowledge of disease prevention, effective self-help strategies for mild to moderate problem, and first aid skill to help others. Interpersonal relationship as a source of stress, but also a source of support. Self-help is a protective strategy, and self-stigma was determined the strongest predictor of willingness to seek help. Evidence of mental health literacy is complex and multi-layer. I think that's all, Dr. Nino. Thank you.
Thank you, Dr. Mira, and thank you for all our distinguished speakers and all participants. Hopefully this session will be beneficial for all of us. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much to all honorable speakers, to Dr. Ninuk as moderator, and to Dr. Mira as our note taker. Ladies and gentlemen, that was a very interesting and interactive discussion sessions we have. Before we move to the next sessions, we will have a break for 30 minutes later. We would like to invite all of you to join us by 15:30 to proceed our last plenary sessions. Thank you very much and see you very soon.
Faculty of Nursing Universitas Airlangga is a reputable nursing education center located in the eastern Surabaya city, a metropolitan with great ambience and comfortable place to study. In line with Universitas Airlangga motto, excellent with morality, the Faculty of Nursing Universitas Airlangga is committed to produce nursing graduates who are competent, professionals, and good moral insight. The Faculty of Nursing at Universitas Airlangga is the best choice for nursing education. Vision and mission.
Our vision is becoming an independent, innovative, leading a nursing program, a pioneer in the development of nursing science and practice at national and international level based on value, nationality, faith, ethic, and moral of religion. And our mission is organizing and developing the academic education and the nursing profession applied science and technology, and then conducting basic research, clinical and innovative community to support education and developing in community services. Organizing dedication on the field of science and nursing practice to the public based on national value, ethic, and moral of religion. And the end, we are organizing the faculty good governance through development-oriented countries and quality and able to competent at national and international level.
Dean Faculty of Nursing, Vice Dean for Academics and Students, Vice Dean for Staff and Finance, Vice Dean for Research and Collaboration. We have 3 programs in our faculty. There are Bachelor of Nursing with A accreditation, Master Program with A accreditation, Doctoral Program, and Nurse Specialist of Medical Surgical Nursing. And also, we already certified by ASEAN University Nation. Our faculty supporting by 49 academic staff and 25 administrative staff. And also, we have total student body around 1,200 students. We have 3 departments: Department of Fundamental, Critical, and Medical Surgical Nursing, Department Maternity and Pediatric Nursing, and Department of Mental, Geriatric, and Community Nursing. We have facilities to develop students' ability to produce professional nursing skills. We have student-friendly libraries with full access to international database. And also, with several institutions and hospitals collaborations, such as Universitas Airlangga Hospital, Dr. Sutomo General Hospital, Dental Hospital of Universitas Airlangga, and Institute of Tropical Disease. To support Universitas Airlangga goals to be 500 world-class university, we have national and international collaboration. We collaborate with international university for exchange program and increasing research and publication. There are Latrobe University Australia, Flinders University Australia, University of College Coast Island, University of Malaya Malaysia, Naresuan University Thailand, Japanese Red Cross Kyushu International College of Nursing Japan, JICA Japan, UGSI Malaysia, Universitas Putra Malaysia, King Abdul Aziz University, Alvan Hook School, and Oita University Japan. Our students also have a great achievement both national and international competition. In order to develop student capability, our students are well facilitated through student club.
Capture, store, access, share, and collaborate around medical multimedia like it's the 21st century. Welcome to Sectra Enterprise Imaging, a consolidated solution made for you. Our solutions are built with an enterprise platform, enabling diagnostic and clinical tools, each tailored to fit your hospital's specific needs. Streamline the complete workflow for any imaging discipline and take care of everything from diagnostics and distribution to management, teaching, and quality improvement. Multidisciplinary collaboration leads to faster and more precise decisions, which can improve clinical efficiency as well as patient outcomes. And with a unified system, you get easy access to all relevant images, data, and patient records integrated seamlessly with surrounding IT solutions. Sectra Enterprise Imaging comes with 24/7 support, designed for 0% downtime with complete data protection, on-premises, or as a cloud service. It's easy to get started, easy to learn, and easy to use, so that your time can be used where it's needed the most. Sectra Enterprise Imaging, made for you.
of Nursing Universitas Airlangga is a reputable nursing education center located in the eastern Surabaya city, a metropolitan with great ambience and comfortable place to study. In line with Universitas Airlangga motto, excellent with morality, the Faculty of Nursing Universitas Airlangga is committed to produce nursing graduates who are competent, professionals, and good moral insight. The Faculty of Nursing at Universitas Airlangga is the best choice for nursing education. Vision and mission.
Our vision is becoming an independent, innovative, leading a nursing program, a pioneer in the development of nursing science and practice at national and international level based on value, nationality, faith, ethic, and moral of religion. And our mission is organizing and developing the academic education and the nursing profession applied science and technology, and then conducting basic research, clinical and innovative community to support education and developing in community services. Organizing dedication on the field of science and nursing practice to the public based on national value, ethic, and moral of religion. And in the end, we are organizing the faculty good governance through development-oriented countries and quality and able to competent at national and international level.
Dean Faculty of Nursing, Vice Dean for Academics and Students, Vice Dean for Staff and Finance, Vice Dean for Research and Collaboration. We have 3 programs in our faculty. There are Bachelor of Nursing with A accreditation, Master Program with A accreditation, Doctoral Program, and Nurse Specialist of Medical Surgical Nursing. And also, we already certified by ASEAN University Nation. Our faculty supporting by 49 academic staff and 25 administrative staff. And also, we have total student body around 1,200 students. We have 3 departments: Department of Fundamental, Critical, and Medical Surgical Nursing, Department Maternity and Pediatric Nursing, and Department of Mental, Geriatric, and Community Nursing. We have facilities to develop students' ability to produce professional nursing skills. We have student-friendly libraries with full access to international database. And also, with several institutions and hospitals collaborations, such as Universitas Airlangga Hospital, Dr. Sutomo General Hospital, Dental Hospital of Universitas Airlangga, and Institute of Tropical Disease. We support Universitas Airlangga goals to be 500 world-class university. We have national and international collaboration. We collaborate with international university for exchange program and increasing research and publication. There are Lathrop University Australia, Flinders University Australia, University of College Cook Island, University of Malaya Malaysia, Nadasaland University Thailand, Japanese Red Cross Kyushu International College of Nursing Japan, JICA Japan, UGSI Malaysia, Universitas Putra Malaysia, King Abdul Aziz University, Alvan Hook School, and Oita University Japan. Our students also have a great achievement, both national and international competition. In order to develop student capability, our students are well facilitated through Student Club.
A very good afternoon, ladies and gentlemen. Now we are back to have our last plenary sessions of today's event, the 13th International Nursing Conference. In these sessions, we have two amazing speakers with Dr. Yuni Sufyanti as moderator and Dr. Retno Indarwati as our note taker. With full respect, we would like to welcome all of the honorable speakers. And now I would like to hand these sessions to the moderator in charge. To Dr. Yuni Sufyanti, time is yours.
Thank you, Miss Sarah. Good afternoon, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. The Honorable, our speaker and distinguished guests, and all participants at the 13th the International Nursing Conference Continuous Innovation for Sustainable Health and Climate Resilience. Welcome in this plenary session. This is the last plenary session. And in this session, we have two speakers who are Ibu Roro Sri Nuryati Madiputi from University Muhammadiyah Banjarmasin, who share about the student care stunting program important as an innovation in stunting prevention. And the second speaker is Ibu Dr. Ilya Krisnana from Faculty of Nursing, Universitas Erlangga. She will share about the intervention cooperative oral hygiene education for parents to prevent oral mucositis on children suffering leukemia. Before we start in this session, I will read the rule of this session. The time for each speaker to present is 15 minutes, followed by a discussion after all the speakers have delivered their presentation. For questions, please submit via chat menu on the Zoom, and all participants can ask questions directly with click raise your hand in your account. Okay, before all speakers start the presentation, I will invite all speakers and say to hello Ibu Sri. Are you in Zoom? You can hear your hello. Hello, Ibu Sri. You still mute? Maybe you can unmute your voice.
Hello. Yes, I'm here.
Okay, thank you, Ibu Sri. And the second speaker, hello, Ibu Ilya. I can hear your voice. I can hear your voice.
Yes, Ibu Yuni, I'm here. Thank you.
Okay, thank you, Ibu Ilya. Okay, ladies and gentlemen, we will start in this session, and I would like to invite for the first speaker. Please welcome to Ibu Sri Nuryati as the first speaker to start your presentation. But before, Ibu Dr. Retno as a note taker to will read the CV of Ibu Sri Nuryati. Please, Dr. Retno.
Thank you, Dr. Yuni. Ladies and gentlemen, I will read the curriculum vitae. Ibu Roro Sri Nuryati Masdiputri, SST Magister Kebidanan, is a lecturer in Universitas Muhammadiyah Banjarmasin. For educational background, graduated from Associate Degree Midwifery Educator, Stikas Aisyah Yogyakarta in 2011, graduated from Midwifery Master Program, Universitas Aisyah Yogyakarta in 2018. Ibu Sri has experience as a speaker for health and beauty program talk show in Banjarmasin Post Online Program. And the publication of Ibu Sri Nuryati is The Relationship Between Confidence and Anxiety in Speaking in Front of the Class for Diploma for Student Midwife Educator Class Stikas Aisyah Yogyakarta. chronic energy deficiency in pregnant women at Pekauman Health Center, Banjarmasin. And Ibu Sri Nuryati also wrote the book on the philosophy of midwifery. That's all, Ibu Yuni.
Thank you, Dr. Retno. I would like to invite Ibu Sri Nuryati. Welcome, please welcome Ibu Sri Nuryati. You have 15 minutes to present your presentation. Time is yours. Ibu Sri, you will share your presentation yourself, or maybe we can help your presentation. I can hear your voice. Maybe you can unmute your voice.
Okay, I need to
Okay.
have to, okay, I will share my presentation.
Okay,
But
thank
the
you.
host disable participant sharing the screen. Okay.
Okay.
Is my presentation visible? Do you can see my presentation?
Yes.
Is my presentation visible? Sorry. Okay.
Yes. You can start your presentation.
Okay, thank you, moderator. I would like to share information and topic about stunting. We know that stunting is one of national issue in Indonesia. If we can fix the problem about this, we will get lost our generation. So in this time, I would like to share about that. The next slide. Okay, I start from Vision and Mission Indonesia is a background. In 2045, Indonesia have a golden generation. Because now Indonesia population majority is productive age. It means Indonesia can have excellent human research to advance Indonesia. So we can easily reach SDGs target in 2030, but we have a problem in our generation, that is stunting. Next slide, please. Stunting is one of national issues in Indonesia. Stunting is chronic malnutrition in children in the first of 1,000 days of life. This lasts a long time and cause stunted brain and child development. According to SSGI 2021, Indonesian stunting case rate is 24.4%. Next slide, please. Next slide, please. Okay, we can look at this graphic. This is a description of stunting case in Indonesia. We can see that Nusa Tenggara Timur as a higher province, it's past national number, and Bali is the lowest stunting case in Indonesia. Next slide, please. Okay, we can divide stunting impact to short period and long period. The short period stunting impact is can increase intelligence, and then for long period stunting impact is this can see in my slide presentation. Next. Okay, this is stunting stunting is caused by multidimensional factor in the first 1,000 days of life. Start from prenatal period to 2 years old of children. The next slide, please. This is a circle of stunting. Stunting happen start from preconception period. You can look in my presentation. This green line is chain break to prevent stunting case. The student care stunting program, or we call mahasiswa penting is one of way to break the chain stunting case in Indonesia. The way is prevent the anemia, lack of micronutrients, malnutrition, anemic and other micronutrient deficiency, low immunity, impaired fetal growth, low birth weight baby, decreased immunity, inadequate cat-up growth, and we can chain break and we can save the golden period of first 1,000 days of life. Next slide. Okay, the government effort. Government by BKKBN. BKKBN is National Population and Family Planning Agency have a target in case of stunting in Indonesia. There is 14%. So we have to decrease stunting case from 24.4 to 14%. Of course, we believe we can do it. Yes. Okay. Next slide, please. This is a student care stunting program. This one of innovation that made by National Population and Family Agency collaborate with Minister of Education and Culture. The name of this activity is implementation of freedom learning in freedom of campus in Indonesia. It's called Kampus Merdeka. Okay, next slide, please. This is an implementation of mahasiswa penting in the implementation of freedom learning in freedom of campus. Next slide, please. Kampus Merdeka or freedom of campus is the policy of Minister of Education and Culture to encourage students to be mastered in various science that are useful, not only one specific science. Freedom of campus provide opportunities for students to study 3 semesters outside the program study. Next slide, please. Okay, this is an activities in freedom learning in freedom campus. Perwira penting is entrepreneurship care program and stunting intervention. Rindu penting is integrate care research and stunting intervention. Bangdes penting is building care village and stunting intervention. Proyeksi penting is independent project for stunting care and intervention. Asmendik is teaching assistant for stunting care and intervention education unit. And then Procam penting is humanitarian care project and stunting intervention. And the last is Prakar penting is career internship and stunting intervention. Next slide, please. This is a process student care stunting activity. The first is preparation. Preparation include campus identification and then MOU between campus and family planning agency and coordination and area mapping. And then the next is recruitment. The next is training, and then implementation and guidance is include socialization, advocacy, education, assistance to target group, and then assistance and facilitation to the family association team, and then ensure that all targets are recorded, obtain services, take advantage of intervention, and the last is assistance and facilitation to dahsyat activator care. And then the next of process is analysis and problem identification, and the last process is report and reference. The next slide, please. This is our family support team. Family support team is midwife, volunteer, and family development team, or we call PKK. The task is early detection of stunting risk factor, specific and sensitive, and assistance and surveillance, counseling, facilitation, or referral service, and acceptance of social assistance. From preconception to toddler, to identify stunting risk factor and provide services for health service and other services to prevent stunting risk. Next slide, please. Okay, this is a nutrient intervention through Dahsyat. Dahsyat is community empowerment activities in an effort to fulfill balanced nutrition for families at risk of stunting, especially from underprivileged family, to improve the nutritional quality of the community, especially for families at risk stunting by optimizing various resource in order to accelerate effort to reduce stunting at the village level. The next slide, please. This is an important student program assistance through stunting thematic community services program. Socialization include education, awareness raising, advocacy on stunting and assistance in healthy kitchens to prevent stunting directly to the community. The activity is visit to target groups, homes to post stunting prevention poster, and then counseling at Posyandu and routine community activities. And then the last is educate the healthy means for healthy kitchen measures to overcome stunting. The next slide, please. This is activities already and currently have memorandum of understanding with BKKBN. Next slide. Okay, this we can see in this slide student role in student care stunting program is identify stunting, and then socialization, extended family and neighbors, and then invite friends, and then take care and help volunteer in the environment, and the last is publication and socialization in social media. So the student as a socialization agent here. Next slide. This is activity in student care stunting program. The offline activity is sending education material like a poster to home, and then direct assistance to the community on group discussion, and the online activity on stunting care from student is messaging by creating group sharing, education in media social, focus group discussion by virtual meeting. This is the last of my slide. Thank you for attention and opportunity. Thank you.
Thank you, Ibu Sri, for a great, interesting presentation, I think, and the highlight of your presentation about, I think, one of rule importance for the educational institution, I think, in this case, for the student activities to prevent the stunting case. Okay, thank you. And I will ask you to stay in the seminar room because the question and answer session will be held when the second speaker finish her presentation. Thank you. Okay, let's going to the second speaker. We would like invite the second speaker who is Ibu Dr. Ilya Krisnana. But before Dr. Retno will read the CV of Ibu Dr. Ilya Krisnana. Please, Dr. Retno.
Okay. Thank you, Dr. Yuni. Ladies and gentlemen, I will read the curriculum vitae Dr. Ilya Krisnana, Eskapnas Magister Keperawatan, as lecturer of pediatric and maternity nursing, Faculty of Nursing, Universitas Airlangga in 2006 until now. Educational background, Ibu Ilya graduated from bachelor in 2006 and the doctoral program from Universitas Airlangga in 2021. Ibu Ilya has many publications according to its field, among them maternal behavioral factor of mothers with neonatal death in the perinatal at period, factor associated with student snacking consumption, and determinant of under 5 mortality in Indonesia nationwide study. I think it's all, Dr. Yuni.
Thank you, Dr. Retno. And I will invite Ibu Dr. Ilya to deliver your presentation. And you have 15 minutes for your presentation. Ibu Dr. Ilya. Time is yours.
Okay, thank you Ibu Yuni for the time. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. At this time, I would like to share about the intervention of cooperative oral hygiene education or COHE for parents to prevent oral mucositis on children suffering leukemia. This title is taken from the topic of my research at the doctoral nursing program. Okay, next slide. Okay, thank you. We can see on the screen that Indonesia has the first position with number of cases of cancer for children when compared to other countries in Southeast Asia. Indonesia has the first position or the highest number of the case of cancer in children. Next slide. Next slide, please. Okay, next slide. I'm sorry. No. Number 3. Previous. No. Previous. No. Okay. Okay, yeah. We can see on the screen that the types of cancer on children. There are 10 most types of the cancer on children, and the highest position is leukemia. This is the data taken from WHO. This is the data from WHO on children with 0 until 14 years old. Therefore, we interest to did a research about leukemia on children. Next slide, please. Okay. As we know that the treatment of cancer, especially in leukemia children, is chemotherapy, and then radiotherapy, and the last is hematopoietic stem cell transplantation. Okay. And the main treatment for leukemia is chemotherapy. However, this therapy can cause several side effects, and one of the side effects is oral mucositis. So on the next slide, we will talk about the oral mucositis. Next slide, please. Okay, this is the picture of oral mucositis on children. Oral mucositis is a painful and inflammatory ulcerative lesion occur as an adverse effect during chemotherapy, radiotherapy in children with acute lymphoblastic leukemia. Oral mucositis due to cancer therapy occurs 40 until 80% of children, and oral mucositis is a serious complication of cancer treatment or cancer therapy when the children receive chemotherapy. Oral mucositis becomes clinically apparent on 4 until 5 days after chemotherapy and generally peaks on 7 until 14 days after chemotherapy. This photo is the condition one of my respondent. So his mother sent photo to me, and this is the photo is a part of the evaluation on 7 days post methotrexate chemotherapy. And from this picture, he is wearing a grade 4 for oral mucositis. Okay, next slide, please. Okay, for diagnosis or for classify the oral mucositis, so we use the WHO oral mucositis index. There are 5 grades for oral mucositis using the WHO. The starting grade is grade 0. Grade 0 means that no changes or the children has a normal mucose of oral. And then the grade 1, the children has a soreness or erythema in their mucose of oral. And then the grade 2, the children suffering erythema and ulcers. So the patients can eat solids, but on the grade 3, the patient or the children suffering ulcers, and then the patient require a liquid diet only. And the last is the most severe of the grade for oral mucositis is the food in grade 4. So in the grade 4, the patient or the children cannot tolerate with the food, so the food intake is not possible. So they must give the parenteral nutrition. Okay, next slide. If the children has a mucositis oral, or to prevent the mucositis oral in children with the chemotherapy, so there are 6 management of oral mucositis in children. The number 1 is oral care. Oral care is beneficial to prevent oral mucositis for patient with the chemotherapy. And the second one is the pain control. Pain due to oral mucositis can affect food intake in children and oral care, and also quality of life. And the third one is the nutritional support. Based on the American Society for Parenteral and Enteral Nutrition states that the parenteral nutrition should be considered in children who cannot maintain adequate oral or enteral nutrition for 5 until 7 days. And the fourth one, number 4, is oral decontamination. Microbial colonization of oral mucositis lesion exacerbate that the severity of oral mucositis, and decontamination of the oral cavity will reduce the severity of mucositis oral. Okay, and the number 5 is palliation of dry mouth. The palliation of dry mouth when the patient undergoing chemotherapy, so they often experience temporary or permanent xerostomia and hyposalivation. So this situation can exacerbate inflamed tissue and increasing the risk of local infection. And the last, number 6, is the management of oral bleeding and therapeutic intervention for oral mucositis. Local intraoral bleeding can usually be controlled using a topical hemostatic agent. So, from this management, we focus on the prevention of oral mucositis. So we did the oral care performed by the parents of children suffering leukemia. Okay, the next slide. As we know that the oral care is a standard first step to prevent mucosal injury. Through the oral care, so the oral hygiene condition can be created if the parents able to implement oral care properly. So this is the nurse role to make the parent able and competent to do this job. So oral hygiene education have an important place to achieve it. Next slide, please. Okay. There are two methods of the oral hygiene education, or OHE. As we know, we study that there are two methods of the oral hygiene education. Number one is individual OHE, or oral hygiene education. And number two is cooperative oral hygiene education. Okay, but so far the method that is widely used is the individual method, while the group method is very few or even I have never found. Next slide. Okay, for the cooperative oral hygiene education, we use the cooperative learning method. Cooperative health education based on cooperative learning method. So besides the knowledge, we can get several benefits from the cooperative method. This method also produces several advantages, including individual accountability, and then social skill and teamwork. Individual accountability means that someone has a responsibility to produce or achieve the goals that have been set with the group. And then the social skill means that during educational activities, the participant can interact each other in a group. So not only knowledge that they can get, but also improves a good relationship between participant in a member of the group. And then the teamwork means that the participants have to do together with other member of a group so they can success to achieve the goals together. Next slide. Okay, on the screen, we see the positive interdependence. The main element in a cooperative learning method is a positive interdependence. There are 4 components. Number 1 is positive goal interdependence, and the number 2 is positive reward. Number 3 is positive role interdependence, and the last is positive resource interdependence. Okay. Positive goal interdependence mean that every member of group has interdependence to achieve the goals, and positive rewards mean that a member of group who can achieve the goal, they have to get rewards from other. This reward can increase motivation of member to improve their perform of oral care for their children. And positive role interdependence mean that they have organized structure and on the group, and they respect and obey for the regulation. And the last is positive resource interdependence. It means that everyone on the group should help member of group who lack of property to give a perform oral care. Okay, next slide. Okay. We start to discuss about my study. My study is using the inclusion criteria. Number 1, the inclusion criteria is the mothers of leukemic children who meet the following criteria. Number 1 is the children aged 8 until 18 years old leukemic children. And then number 2 is the children who has received methotrexate chemotherapy. And the third one is the children who has thrombocyte level more than 20,000 meter per cubic, or they without a bleeding. And the last is the mother willing to be a respondent after they give a signature for the informed consent. The next slide. Next slide, please. From the screen, we see that this is our flow chart of the cooperative oral hygiene education. There are 6 steps for doing cooperative oral hygiene education. The step 1 is determine subtopic and organize into a research group. and then plan the investigation. The both of this step is held on first meeting with time allocation in 45 minutes. And then on the next day, patient or the respondent have to investigation with the 4 element of the cooperative learning method. And this is need the allocation time is 60 minutes. And then the 4 until 6 step is held on the third meeting with time allocation is 45 minutes. On the fourth step, the group plan the presentation, and then on the 5 steps, the group presentation, and then the last is evaluation. Next slide. Okay, this is the daily of oral care that mother has to apply for their children every day. Start from day 1 until 14 days after chemotherapy. In the morning, mother should apply for their children brush teeth and gargling with normal saline after 30 minutes after their breakfast. And then after this, spray with chlorhexidine 0.2%. And the noon, they have to apply for their children to gargling with normal saline 30 minutes after lunch. And on the evening, they gargling again with normal saline 30 minutes after dinner. And the night before bed, they have to apply for their children toothbrush and gargle with normal saline. And then after this, 30 minutes after toothbrushing, they have to apply for their children spray with chlorhexidine 0.2%. Next slide. The set of oral care that we need is number 1 is toothbrush, and number 2 is toothpaste with the non-detergent toothpaste, and then gauze, and number 4 is an NaCl liquid, and number 5 is mouthwash spray. Next slide. Okay. This is the picture of the set of oral care for the cooperative oral hygiene education. Next slide. Cooperative oral hygiene education applied on 2 settings, in the hospital and then in the home. In the hospital, the parents join in 3 times meeting for education using investigation method, and parents also gave a booklet as a media contain many forms that can be used to report the daily of oral care. And then at home, the parents join on WhatsApp group with the name is Group COHE, and also implementation daily of oral care. And then on the 7 days and 14 days after chemotherapy, the parents must give the report to the researcher about the oral mucositis presence or incidence of oral mucositis, and the routine daily oral care as a post-test evaluation. Next slide. This is the result of the study, and on the table so that the intervention group perform prevention behavior better than the control group on toothbrushing and mouthwashing aspect. And there are significant difference behavior among intervention and control group using statistical analysis. Next slide, please. On this table, so that the peak of mucositis oral or oral mucositis incidence occur on 7 days post chemotherapy. On control group, so showed more for oral mucositis appearance than intervention group. the incidence of oral mucositis on intervention group on 7 days post-chemotherapy was 15.79%, while the incidence of oral mucositis on control group was 36.84%. And this result answer the hypothesis that the cooperative oral hygiene education, or COHE, can improve oral mucositis prevention behavior among parents. And the outcome was that cooperative oral hygiene education reducing the incidence of oral mucositis on children with chemotherapy. Can the next slide? This is the last slide. For the conclusion that leukemia has the highest number of cancer for children, and that oral mucositis is the common side effect of chemotherapy, especially methotrexate. And the peak of incidence of oral mucositis occur on 7 days post-chemotherapy. And oral hygiene education is important for the management of oral mucositis prevention, and cooperative oral hygiene education improve oral mucositis prevention behavior among parents of children suffering leukemia and reducing incidence of oral mucositis. Next slide. I think that's the end of my presentation. Hopefully this presentation give the benefit for all of us. Thank you for the attention. Stay safe and healthy. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Ilya, with a great presentation. I think about the one of nurse intervention, I think for the children with the cancer, and COHE, Cooperation Oral Hygiene Education, is one of innovation in nursing intervention, I think. Okay, for because this is the end of the presentation for all speakers. In this session, I will open the question and answer session. So I would like invite to all all participants to give the question for the first speaker or the second speaker. I have no read, I think in, okay, maybe the all participants can give your question for Ibu Sri or Dr. Ilya. You can give your question directly with click your raise hand in your chat room or the akun Zoom, please. Okay. Okay, there is one question in the chat room to Dr. Ilya. Dr. Ilya, when is the effective time to give oral hygiene education to patient undergoing chemotherapy? Please, Dr. Ilya.
Okay, thank you, Ibu Yuni, for the great question, I think. When the best time for apply the oral care or perform oral care? I think every day we should apply oral care, especially toothbrushing 2 times every day. So when the children get the chemotherapy, so they have maintain the perform oral care every day 2 times toothbrushing or gargling like this. So I think every day is the best time to apply the perform for oral care, especially for the children get the chemotherapy.
Okay, thank you, Dr. Ilya. I think it's clear for the question from Ibu Ika Nur Pratiwi. Maybe one question from to Ibu Sri. If there are any question, I have one question. I have one question for Ibu Sri. Okay. Okay, in the chat room, there are one question from Ibu Cynthia. In your opinion, how to increase the effectiveness of stunting prevention program in Indonesia? Please, Ibu Sri. I can't hear your voice.
Okay, thank you for the opportunity. I will answer the question that how to increase the effectiveness stunting prevention program in Indonesia. Many ways to prevention stunting case in Indonesia. One of the way is student care stunting program. That is. Thank you.
Okay, the case activity of student program, I think to contribute to prevent the stunting program. Yeah.
Yes.
Okay. Thank you. Thank you, Ibu Sri. And finally, due to the limited time, we will end this session. If there are still any question, I think to all speaker, you can send your question to email to the all speaker. Thank you. And thank you for all speaker that have delivered.
Program as an innovation in stunting prevention. There is many activities in this program, such as independent project for stunting care and innovation, building care village, integrated care research, and stunting intervention, entrepreneurship program, teaching assistant for stunting care and intervention education unit, humanitarian care project, and career internship. The activities dahsyat is community empowerment activities in effort to fulfill balanced nutrition for family at risk of stunting. And the student role are very important for identify stunting, socialization, invite a friend, take care and help volunteer, and publication in social media. And conclusion from Dr. Ilya. Cooperative oral hygiene education divided into two phases, activities in hospital and at home. In hospital, 3-time meeting, group investigation, and COHE booklet. At home, the activities are WhatsApp group, 11 days oral care and observation, and cooperative oral hygiene education, improve oral mucositis prevention behavior, and reduce incident of oral mucositis. I think it's all, Dr. Yuni. Thank you.
Thank you, Dr. Retno. And the next session, we will the awarding certificate for the all speaker to appreciation in this session for their participation. Please, the IT team to share certificate to Ibu Sri Nuryati. Ibu Sri Nuryati Mas Diputi, this is your certificate. Please accept your certificate. Thank you for your presentation. And please share the certificate to the Dr. Ibu Ilya. Ibu Dr. Ilya, this is your certificate. And
Thank you
thank you for your presentation and a great presentation, I think. And Thank you for all speakers for the last plenary session, and we can end this session. And as the moderator and Dr. Retno as a note taker, sending apologize if there are any problem in the guideline to plenary session in this at the end of the plenary session. And thank you for all participants and all speakers. Wabillahi taufiq wa hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much to the moderator for leading such a wonderful discussion at our last plenary session. Ladies and gentlemen, this is the end of our first day of the conference. And tomorrow, we'll be back for the oral presentations and the closing of the 13th International Nursing Conference, which will be started at 8 o'clock Jakarta time. On behalf of the committee, I would like to thank you for all of your participation and attentions in the 13th International Nursing Conference with the topic Continuous Innovation for Sustainable Health and Climate Resilience. Hopefully that you enjoy the conference, gain knowledge, and networking through these occasions. Lastly, allow me, Sarah, to officially close today's event and excuse myself. See you tomorrow, and wassalamualaikum warahmatullahi wabarakatuh.